without further ado, I'd like to introduce Dr. Ann Beaton. Dr. Beaton is an associate professor at the SUNY College of Optometry. She has a major presence in our basic science courses. Dr. Beaton has a PhD in virology and molecular biology from the Sloan Kettering Division of Cornell Medical College. And she's been with us for previous webinars, and we've had dozens of questions for Dr. Beaton, and we really want to pick her brain and learn from her and learn about this virus. And so her expertise is really beyond just about anybody that I know. So I want to hand this over to Dr. Beaton right now.
Thank you. Good evening, everyone. The Nerdy Science Girl returns for part 4. I'm guessing that most of you out there haven't spent as much time as I have this past summer thinking about, in particular, testing for the virus, and especially since we were last together. So I'm going to share my screen now so you can see what we're going to be up against tonight. Let's see. There we go. So this is part 4, and as I said, I've been thinking a lot about testing, and I'm looking forward to sharing that with you tonight along with an update on treatments and vaccines. So let's start by talking about testing. Okay, so these are the things I'm going to update you on. So let's begin. Okay, so testing, the theme of this part of this talk is don't let perfect be the enemy of good. And here I'm going to be talking about the perfect test, or PCR, the gold standard of testing for diagnosis of disease, versus antigen tests. So why do we test at all? Tests allow us to do the basic task in disease control of identifying sick and separating them from the well. When tests are abundant, they can dispel the fear of contagion. What kind of tests do we need and for what purpose? Individuals with symptoms of disease should be given the gold standard perfect test, in this case PCR, the most sensitive tests available. But those tests can be rendered useless, as we saw this summer when outbreaks raged in parts of the US and test results took up to 14 days to come back. Can antigen tests that are good but not perfect help us through this pandemic? So first, what I want to do is review with you the perfect gold standard for testing, which is still the quantitative polymerase chain reaction. The first step, as you can see up here, is they take a nasopharyngeal swab. I've heard it's like getting a brain biopsy, right? They have to break open the virus particles and isolate the RNA. And in the second step, they take that RNA and use reverse transcriptase to copy it into DNA. And then the process of the polymerase chain reaction takes place, a process in which this DNA copy is then enzymatically copied over and over like a Xerox machine, resulting in a geometric increase in copies. In quantitative PCR, fluorescent dye is included in the reaction, and the fluorescence signal increases proportionally to the amount of amplified nucleic acid. This enables an accurate quantitation of the RNA in the sample. If the fluorescence reaches a specific threshold within a certain amount of PCR cycles, the sample is considered a positive result. So here I'm showing you the progression, starting with a single copy of an RNA molecule. And the lower the amount of starting RNA, the more cycles of amplification are needed to be carried out to reach that fluorescence threshold above background. Starting with a single copy of RNA, after 30 cycles of PCR, right, you have over 1 billion copies now of that original thing that you copied. Let's see if I can get rid of, okay. And if you do 40 cycles, it's actually over 1 trillion. Okay. The higher the amount of RNA to start with, which reflects higher virus load, the fewer number of amplification cycles are needed to detect fluorescence above background. Let me emphasize that the mere presence of RNA does not necessarily mean that there is viable and, more importantly, transmissible virus present. And we'll talk more about this in a few minutes. One slight variation to this molecular test is the test the NBA is using, which is a much less invasive test and also cheaper. It's called Saliva Direct, and as its name suggests, they're using saliva instead of a nasopharyngeal sample. Okay, a good way to visualize the idea that the more RNA that is present, the fewer number of PCR cycles it takes to detect it is the magic penny dilemma. The magic penny asks whether you would rather receive $1 million right now or a month's worth of a magical penny that doubles every day in value for 30 days. In this scenario, you pass $1 million by day 28, and you still have 2 days to go. So obviously that's the better deal, the magic penny, right? Now imagine you started with a magical dollar instead of a penny. In this case, you would pass $1 million by day 21. In other words, the higher the amount you start with, the quicker you surpass $1 million. In the case of viral RNA, the higher the RNA number or viral load to start with, the fewer number of cycles of amplification you have to carry out to detect virus. Okay, so these are amplification plots that are created when the fluorescence signal from a sample is plotted against cycle number. So here on the x-axis, you see the cycle number, and then the fluorescence is on the y-axis here. Amplification plots represent the accumulation of product over the duration of a real-time PCR experiment. The fewer the number of copies of RNA to start with, the more number of doublings you need to get to a certain point. In the magic penny, it's the number of days. For PCR, it's the number of cycles of amplification. So if you look over here at the yellow plot on the far right, this is starting with 10 copies of RNA, compared to the red plot way over here on the left, where you're starting with 10 to the 8th copies. Starting with 10, you get a fluorescence signal above background around amplification cycle 38 and above. Okay, so 38 to 40. You can see in red, when you start with 10 to the 8th copies, you get that amplification signal above background, which is this black line here, around cycle number 14 or so. The cycle threshold is the number the cycle threshold, or CT value is sometimes referred to, is the term used for the number of cycles required for detection of that fluorescent signal above background. The best PCR test can reliably detect in just a few hours as few as 10 to 100 copies of RNA, viral RNA per milliliter of spit or nasal discharge. So the cycle threshold is inversely proportional to the amount of target nucleic acid. That is, the lower the CT level, right, the higher the amount of RNA in the sample. That being said, what happens practically is that for most PCR tests, 40 cycles of amplification are routinely carried out, and if fluorescence is detected at that point, the test result will register as positive. It doesn't matter if the threshold was met sooner than 40. Someone with a lot of RNA will not be differentiated from someone with a small reservoir of RNA. But if the CT values were reported, a test from a person with 1 million copies of viral RNA on their swab, a number considered to be realistic in terms of being capable of transmitting virus, the test could turn positive at a CT value as low as 24. Keep in mind that what is being assayed here is not virus, but rather viral RNA. Okay, without getting too in the weeds in this slide here, this is data that looked at the level of RNA on someone's swab and the ability to detect infectious viral particles in their sample. Scientists took viral swabs and they ran PCR, right? So here you see the cycle threshold values, and also at the same time took those swabs and tried to culture virus from them. In everything to the right,
Okay, I think we're having some technical difficulties, so we're just going to pause here for a second. Dr. Beaton, we are having, we can't hear you at all.
at what point did it happen? Where do I have to go back to, Betsy?
I would yep. Probably just quickly start this one. You were into it a little bit.
Yeah.
Okay,
Yeah,
this
I
slide?
lost you, but
Yeah,
yeah,
this
yeah,
slide.
this slide. This
Okay,
slide.
no problem. I'm good with that. Okay.
Thank you for that.
All right, no problem. Okay, so what I said at the beginning was that of this slide is that without, I don't want you to get too much in the weeds of this slide, but this is data that looked at the level of RNA on someone's swab and the ability to detect infectious viral particles in their sample. In other words, are they able to, transmit? Are they contagious? So scientists took viral swabs, ran PCR, and also tried to culture virus from the swabs. What I want to point out here is this blue arrow. So everything to the right of this blue arrow, which is a cycle threshold of 34, no virus could be cultured from their sample. So even though viral RNA can be detected by PCR up to 20 days or more after onset, and sometimes even longer after symptoms. You hear these stories of patients who are PCR positive for months, right? In general, they can't detect virus, right, after day 8. So a positive RT-qPCR result may not necessarily mean the person still has virus particles and is infectious, right? The RNA that lingers sometimes for weeks after symptoms resolve is just remnants of non-viable virus. Okay, so which is better for routine screening to determine whether someone is contagious and can infect someone else? Rapid tests or these gold standard PCR tests that we just talked about, right? So virus can't be cultured from people with low levels of RNA, even though they may still test positive by PCR for a long period of time. What we really want to know is, can we differentiate people who can transmit virus from those who have low levels of RNA without using the expensive PCR tests that takes a long time to get the result back? Imagine now a completely preposterous scenario, right, where someone returns to college and goes to a party where there's no physical distancing and there's no mask wearing because it's not a Halloween party. To be responsible afterwards, our collegian decides to get a COVID PCR test, even though he or she is asymptomatic, say around here a couple of days after the party, right? So this PCR test would come back positive, but the problem is the results aren't going to come back for 4 or 5 days. And in the meantime, the person is contagious, has enough virus to transmit, but is not being sequestered because they don't have their test results back, right? And they could even be asymptomatic, so they feel fine and they go out into the, to their classes and they see their friends, and now they are exposing a lot of other people to virus. Okay. A recent study in The Lancet found that once test results are delayed more than 3 days, even perfect contact tracing can't stop an outbreak. On the other hand, if that person could take a rapid, less sensitive test at home every day after the party, on day 2 or 3, they might not test positive, but by the time they get to day 4, now you can see they're at the peak of virus, and these rapid antigen tests will tell them that they should in fact sequester and stay home, right? In the earlier days, when their rapid tests came back negative, they probably didn't have enough virus in their noses, in their mouths, in order to transmit it. And so the fact that they were negative is not so bad. So what kind of tests are useful to detect this window of transmissibility infectiousness? So this is where antigen tests become extremely useful. In a perfect world, everyone would know their COVID status every day. For routine screening to detect contagiousness, turnaround time and frequency are really more important than sensitivity. These are screening tests, while you consider PCR to be more a diagnostic test. Testing is a way to drive transmission down to 0, expanding the possibilities to both reduce mortality and to increase personal freedom. Antigen tests look for viral proteins instead of RNA and are a cheaper, quicker alternative to PCR. And they're perfect as a means to screen and stop transmission. They can be administered frequently and are especially good to detect people with high viral loads with the ability to transmit virus, even if they are asymptomatic. Now, these antigen tests aren't new. They've been around for a long time, and many point-of-care facilities actually have the instruments to do them in office for doing routine tests for things like strep throat and for influenza. Note that this is very different from diagnostic testing of sick people, where we need to be able to gather all the evidence possible for why someone is sick. If someone's sick, they really need a PCR test. So see, these are a few of the available rapid antigen tests available for COVID screening. Now, this is the Abbott ID Now. This is the one that is being used at the White House to screen guests. And it's pretty sensitive, picks up about 99% of infectious cases, and it does it in less than 15 minutes. But a negative test in the context of high clinical suspicion, so somebody's not feeling well, they should be sent off for confirmatory testing and have PCR done. The newest addition to the antigen testing arena, which has received EUA, or Emergency Use Authorization from the FDA, is Abbott's 15-minute, $5 Binax Now test that doesn't require special instrumentation, although one drawback is that it still does require a healthcare professional to obtain the sample. It's still a nasopharyngeal sample, and carry it out. And the result can be read on these antigen cards in 15 minutes. The idea is that people who are tested will use the associated free cell phone app that goes with it. If they receive a negative test, will get a temporary encrypted digital health pass by a QR code, similar to like when you print out your airline boarding pass. The digital pass is renewed each time a person receives a negative test and includes the date of that test. Those who test positive will get a message through the app telling them to quarantine, to talk to their doctor, and to perhaps receive a PCR test in order to confirm. These tests are very reliable. The Abbott is saying that they are 97+% sensitive. And they're planning to ship tens of millions of them in September, and are supposedly going to ramp up manufacturing to 50 million tests a month in October. Okay, even though this new Abbott test is a huge step in the right direction, there are even easier tests called paper strip tests that are really cheap, say $1 each, and can be administered and read by people at home. These tests, which are not yet commercially available or FDA approved, in one iteration consists of an antibody to a viral protein, like the SARS-CoV-2 spike protein we've heard so much about, printed on a strip of paper or cardboard. And then you spit in a tube, insert the test strip, and in a few minutes, you see a color change indicating a positive result, kind of like a pregnancy test. So think of these paper antigen tests not as diagnostic tests like PCR tests are, but instead they're quick, inexpensive ways to screen for virus infectiousness. They're designed to be done daily or every other day. A person can go from being not contagious to being extremely contagious in about 2 days. If you only test weekly, you can be contagious for 5 or 6 days, like we saw in that thing I told you about the college kid who went to the party and had the test. So you could be contagious for 5 or 6 days without knowing it and be spreading virus. If you test daily, you are much likelier to know the first day you are capable of transmitting virus. Now, the concern about false positives that might come along with these tests can be allayed by performing repeat tests that look for different antigens, or by using follow-up PCR tests. Now, I just want to tell you that these tests are really not yet available because they don't meet the overly strict sensitivity requirements by the FDA, because they are constantly being compared to PCR, and no antigen test is as accurate and sensitive as PCR is. There's really only about a day at the beginning of an infection when the two tests would actually give different results. I want to emphasize again that these antigen tests are not better than PCR in every instance. When someone has symptoms or at the hospital with severe symptoms, you can't risk a false negative. They absolutely need a PCR test. And there are lots of manufacturers out there that are really, ready to go with these tests, and they include even 3M among them, and Abbott actually has one as well. Now, there's a really cute acronym for this kind of testing. It's called HEART, Home Early Antigen Rapid Testing. To give credit where credit is due, the idea for this at-home, cheap contagiousness screening test has been propelled to the forefront by Dr. Michael Mina, an assistant professor of epidemiology at the Harvard T.H. Chan School of Public Health. and his idea is gaining traction. So these are a few of the articles that have been in popular press. And in fact, on the front page of today's Wall Street Journal, there's another that I didn't have a chance to put in here, but it's actually on page 1. It's titled "Public Health Officials Pursue COVID-19 Tests that trade precision for speed." Okay, so although rapid tests can be imprecise, sometimes missing people with low levels of virus in their system, frequent testing would almost certainly catch positive cases as viral levels rise in people with burgeoning infection. So in other words, if they're negative on day 1, they probably don't have enough virus to transmit it, and maybe on day 2, but by day 3, when they have enough virus to be able to pass it on, they will now test positive. And there's so many ways we could use these tests that are not perfect like PCR, but just good enough to help open things up and allow a return to a semblance of normalcy before we have a reliable vaccine. Think how they could be used. Take a test in the morning, go to school, take a test in the morning, go to work, take a test in the morning, get on a plane, take a test in the morning, go to a show, right? So to return to the theme for this part of my talk, let's not let perfect be the enemy of good. And I encourage you to learn more about this idea at rapidtests.org. Okay, let's switch gears a little away from testing and talk about treatment, some of which we've talked about before in these programs. So we've talked about remdesivir, and it continues to be the only antiviral approved for use that works by interrupting viral replication. It inhibits the viral RNA polymerase. It's most useful for hospitalized patients who require supplemental oxygen. That is when their O2 sats basically fall below 94%. But it would be best given in the first few days or first week of infection, because that's when the virus is replicating. But because it's given by intravenous, right, lots of people actually don't feel that bad in the first week. So they're not in the hospital, so intravenous is not really an option for them. So they're actually working on an inhaled version as we speak. Now, the second week of the viral infection is characterized by this cytokine storm. And this is the week when people are generally the sickest with COVID. Pretty much, virus replication is over by now. And so what has been shown to be quite effective, in fact, the latest information was published just last week in JAMA, is a meta-analysis of 1,700 patients from 7 randomized clinical trials recruited from countries on 5 continents, in which they show that administration of systemic corticosteroids was associated with lower 28-day mortality, especially in critically ill patients, and there was no evidence that a higher dose was of greater benefit than a lower one. There had been some hope that drugs like the IL-6 inhibitor, this is a cytokine that is also elevated, tocilizumab, would help to quiet the immune system in a more specific way. But randomized controlled trials showed no benefit of just using the IL-6 receptor blocker. One of the authors of the meta-analysis in JAMA humorously compared the IL-6 blockers to a Lamborghini solution, while the cheap, widely available steroid drugs are the pickup truck solution and all that is needed. Hydroxychloroquine, hopefully this is the last time I'll mention this in a CA event. Suffice it to say that in a randomized controlled trial, it showed no benefit. Since there really isn't any great treatment yet for early COVID disease, what's in the pipeline? So there's another antiviral drug called favipiravir, and this is another RNA polymerase inhibitor, and it is being used now in Japan to treat flu. It is in a phase 3 randomized controlled trial now as a treatment for COVID, and it did show a modest decrease in time to symptom resolution. EIDD2801 is an oral drug that has the ability also to disrupt viral RNA polymerase, and it's also its proofreading function. In addition, it blocks RNA polymerase in a different way than remdesivir, potentially making these two drugs complementary. So perhaps I could use them together to get an even better effect. It has become pretty much standard treatment for COVID patients to be treated with anticoagulation drugs. So most patients are being treated with low molecular weight heparin, both in the hospital and for actually quite a long time after they are discharged as well. Convalescent plasma was given emergency use authorization on August 24th by the FDA. And this is for allowing plasma from recovered COVID patients to be infused into hospitalized patients. This continues to be controversial, and the bottom line is that there has not been a randomized controlled trial that shows benefit. Every patient who received plasma received other treatments as well. So even in the best case scenario, convalescent plasma is not a panacea, and it is best a stopgap measure, the benefit of which has not been proven scientifically. And treatments with it, I want to point out, are not benign, keeping in mind, for example, that plasma has clotting factors. And since there's so many coagulopathies with patients, it's probably not a good idea to give them plasma as well. There are lots of monoclonal antibodies that are in phase 3 trials. Now what are monoclonals? They're laboratory-made versions of proteins of antibodies that are naturally produced by the immune system in response to pathogens. Neutralizing antibodies, whether they're natural or monoclonal, as you can see here. So here, these Y-shaped things, these are the antibodies, and you can see they are binding to the spike protein on the virus. And when that happens, it prevents the virus from binding to the receptor, the ACE2 receptor present on cells, right? So these monoclonal antibodies may be good to provide short-term protection from SARS-CoV-2 and could serve as important components of the pandemic response until vaccines become available. And finally, let's talk about viral immunity, reinfection, and vaccines, right? So let's start with whether we should be very worried about all the reports about disappearing antibodies in patients who have recovered from COVID, and what does that mean about a vaccine, right? So let's look at the basic kinetics of an immune response to either a natural antigen or an immunization. When our immune system encounters a new virus, like SARS-CoV-2 for the first time, some of our plasmablast B cells release a first flush of antibodies that can stick to and even neutralize the virus. This is the primary immune response, and it's generally mounted within a couple of days. But those first antibodies are generally short-lived. They typically don't adhere that strongly, and the cells that produce them don't last that long. The first antibody that arises is usually the IgM isotype, followed by IgG. As you can see, it's perfectly normal for the primary immune response to wane over a relatively short period of time. Your immune system then files away this first encounter so that should it meet the same antigen again, it can mount a much more rapid and vigorous response, a secondary memory or anamnestic response. And that's what you see here on the right half. A challenge leads to a faster response and generally a much higher titer of antibody. Memory B cells, and the same is true for T cells, generated during that initial encounter are primed and waiting for that antigen to reappear. So the fact that antibodies of SARS-CoV-2 disappear over the course of a few months is really not surprising at all. Now, the long-lived plasma cells, these are terminally differentiated B cells that secrete even better, more tightly binding antibodies, are generated in structures called germinal centers, transient structures that are found in the lymph nodes and the spleen. In these germinal centers, B cells undergo sort of fast-track evolution, proliferating rapidly and deliberately introducing random mutations to the antibody encoding genes, increasing the chances of producing a few clones that can bind very tightly to the virus and squelch it. Interestingly, an analysis of lymph nodes and spleens from deceased COVID patients showed that some severely affected COVID patients lack germinal centers entirely. And without them, the body can't make lasting antibody immunity to pathogens. The question about what this means for a vaccine is that it might not have any bearing at all, as vaccination typically generates good germinal centers, and in general, vaccines are designed to trigger a robust and durable immunity that is actually superior to natural infections. And what about all that we've heard about reinfections, right? So there now have been a couple of real documented cases of reinfection with SARS-CoV-2. The first was this Hong Kong patient that was infected twice. Now, how did they know he was reinfected as opposed to just having that long tail of PCR positivity? They actually took the viral RNAs from what they then thought were the patient's two infections, and they were in fact right, because they sequenced them and found the two viruses to have distinct sequences. His second infection was detected by a routine screening protocol carried out on everyone coming into Hong Kong, in his case after a trip to Spain. He didn't have any symptoms, but his saliva sample was positive for the virus months after his first infection. The lack of symptoms upon his reinfection is presumably because his immune system did what it was supposed to do, and his memory response kicked in quickly. But in at least one case of the handful of reinfections reported so far, the disease was worse upon reinfection. This is the so-called Reno patient. Researchers have surmised for a while that people might become vulnerable to COVID-19 again sometime after recovery, based on how our immune system responds to other respiratory viruses, including the 4 common cold coronaviruses. It's possible that these early cases of reinfection are outliers and won't be typical of the tens of millions of other infections in people who have already shaken off COVID-19. The real question that should get the most focus, and it is just too early to tell, is what happens to most people? And the most important question for reinfection, with the most serious implications for controlling the pandemic, is whether reinfected people can transmit the virus to others. And we just don't know the answer to that yet. Even if the Hong Kong case is an outlier, it points to a few important implications. For one, people who have recovered from COVID-19 should also be vaccinated, and they should continue following precautions like wearing a mask and physical distancing. Immunology is complicated. We don't have all the answers yet. Okay, let's talk about vaccines and start off by talking about the differences between sterilizing vaccines and disease-preventing or therapeutic vaccines. Sterilizing vaccines and sterilizing immunity means that they would work by completely preventing infection. An excellent example of a very efficacious sterilizing vaccine is the one that's used to prevent measles. Other vaccines work by preventing disease. For example, the flu vaccine is a non-sterilizing vaccine that prevents the immunized individual from getting the disease, but may not stop infection completely in the upper respiratory tract. In the case of the COVID vaccines, the ChAdOx1, this is actually the one that the trial's being halted, which we'll talk about in a minute, was actually used in the preclinical trials to inoculate macaques. It actually protected them from pneumonia, but they still could find virus, which replicated to high levels in the macaques' upper airways. I think we can agree that a sterilizing vaccine is the aspiration, but we would be satisfied with a therapeutic vaccine that prevents COVID disease and symptoms. So this is a list of the SARS-CoV-2 vaccines that are now in phase 3 trials, right? So phase 3 are efficacy trials that are random controlled trials in which tens of thousands of people are enrolled. Half of the population receives the vaccine, half receives a placebo, and then they collect data on the number of infections in each arm of the trial to see if the experimental vaccinated arm has a lower infection rate than the placebo arm. The FDA has said that a vaccine would have to protect at least 50% of vaccinated people to be considered effective. Now, most of the vaccines, these are the ones on top here, are targeting the spike protein on the outer viral surface, and in earlier phases of the trials have been shown to produce neutralizing antibodies that can bind the virus and, for example, block its entry into cells, like the monoclonal antibodies I showed you in a previous slide. One concern about some of these vectors that are based on adenovirus 5 is that adenovirus 5 is actually a common cold virus, and there's a high seroprevalence of it in humans already, as many people have already had a cold that is caused by it, and they may have already made antibodies to it. And the question that has not been answered is that would that prevent them having a good immune response to the virus that has the spike protein, for example, inserted in the adenovirus 5 genome. Both the chimp adenovirus, that's this one, and the adenos 26 vectors are unlikely to encounter previous antibodies in someone. Now, the inactivated virus vaccines here on the bottom are different. They are inactivated whole virus which is one of the classic vaccine techniques. So they take an infectious virus and they alter it so that it can infect cells and replicate, but still retains enough of its protein surfaces to set off a useful immune response. The biggest news on the vaccine front, which you may have heard in the news yesterday and today, is that AstraZeneca, so that's this vaccine up here, the ChAdOx1 vaccine, has halted or paused global trials of its coronavirus vaccine because of a serious and unexpected adverse reaction in participant, which has been reported to be symptoms consistent with transverse myelitis. How long the hold will last is unclear. The company described the halt as a routine action, which has to happen whenever there's a potentially unexplained illness in one of the trials, while it is investigated, ensuring we maintain the integrity of the trials. Stay tuned for more on this. There's obviously going to be more. And in an unprecedented announcement, 9 drug companies issued a joint pledge on Tuesday that they would stand with science, those are in quotes, and not put forward a vaccine until it had been thoroughly vetted for safety and efficacy. And finally, I just want to leave you with an interesting story about some scientists who are working on their own response to the pandemic, using their knowledge to develop and use do-it-yourself vaccines, going so far as to set up a nonprofit. One of them is called RADVAC, Rapid Deployment Vaccine Collaborative. In the case of RADVAC, they're using synthetically produced peptides. So they know the sequence of the RNA, they go to the codon chart, they produce viral peptides from that, and then they wrap these viral peptides in a nanoparticle and have been spraying them up their nose. And they're wrapped in something that contains chitin, right? So that's the stuff that you find, for example, in the shells of crabs, right? And in fungal cell walls. Chitin in the nanoparticle delivery system also acts as an adjuvant, which is a substance that is often included in vaccines to boost the immune response. Very interestingly, these scientists are not filing patents or protecting their intellectual property, but are encouraging others to build on their work through the Open COVID Pledge that promises to make their intellectual property free for use in ending the pandemic. You can find the list of materials and equipment needed in case you're interested in making a do-it-yourself vaccine yourself, along with their protocols on their website, along with their white paper that includes all the scientific details. So you can go to you can Google RADVAC and find all of that information. The vaccine has been used repeatedly over a few months by over 20 self-experimenters, and they report that the only complication has been a bit of a stuffy nose. So that's a snapshot of where we are. I couldn't cover everything that's out there, but I still say, as I have from the beginning of these CE talks, that science is the way out of this. For anyone who wants a lot of reading material, I have a list with lots of references on it that I'd be happy to share with you. And that's it for my report.
Thank you very much, Dr. Beaton. I actually want to open it up now for any questions that need to come in. So if we have any questions, we'll wait a few moments.
Yeah, I'm just going to add something. It's interesting because the first couple of times that Dr. Beaton's been on, we've literally had dozens and dozens of questions. So I think people have really educated themselves quite a bit about what's going on with the virus, because we're certainly not seeing the level of questions we've had previously. And perhaps you've educated everyone too, Dr. Beaton.
That would be, that's what we're trying to do.
But I have a question for you about the reinfection.
Yeah.
And the person who came back from Spain to Hong Kong. Do they have any sense of what his viral load was?
I don't know the answer to that. I think they just did PCR. But what's most interesting about that is that in Hong Kong, they are testing everybody who comes in. Yeah. Right. So everybody who comes off a plane gets tested, right? And if you test positive, then they put you in a hotel and you have to stay there for at least 2 weeks, right? So their numbers are low and they want to keep them that way. Yeah, but that's a very good question. I don't know what is viral.
Yeah, we have a question in, and it's certainly the $1 million question. What's the timeline you expect for vaccination to be widely available?
Well. I really don't expect it to be available by the election. I think that most people really feel like it's not going to be, certainly till 2021. And I think the worst thing that could happen is to put out a vaccine that had some adverse effects, right? So I think we have to be very careful that we put something out that's extremely safe and efficacious. And so if it takes a little longer, I think that we should be patient and wait for that. But I think like Dr. Fauci, who's a much smarter person than I am, certainly doesn't expect anything before late this year or early next year at the very earliest.
So just to add on to that question, let's say, I don't know, April 1st, 2021, we have a viable vaccine. What before then? What in the next 6 months, Dr. Beaton, do you see? Just continue along the way we are? Do you have any sense of which treatments might be available for us? Are there other, I noticed that you didn't speak to the polio vaccine. We had talked about one of the previous programs, or the pneumococcal vaccine, I know has been known to
and the
boost
BCG
immunity.
vaccine
Yeah,
as well.
And the BCG vaccine as well. I think we talked about that on one of the previous programs.
We did.
But maybe, if you don't mind, do you see that as being something that might become useful?
I highly doubt that in this country we're going to use the BCG vaccine, because if you do that, you take away the ability to screen for tuberculosis by using the PPD test, right? So I highly doubt that we're going to do that, because that takes away a very good screen for TB. I don't see any downside really to the oral poliovirus vaccine. Everyone in this country has been vaccinated, so it shouldn't cause any problems. But I was trying to get the point across that I really feel like the way out of this are these rapid tests. If everybody had a rapid test every day, right? You spit on a piece of paper, it's negative, you go out. If you spit on a piece of paper, it's positive, you stay home. And that is what really could open things up again. So that's really, I'm feeling that is really the best way until we have a good vaccine that everybody trusts. That's the way for us to kind of get back to a semblance of normalcy.
Thank you, Dr. Beaton, again.
My pleasure.
I'm sorry, I thought I just saw a question come in, but I did not.
Oh, no, that was it.
Yeah.
No more questions come in.
Yeah, so thank you again, Dr. Beaton. And,
my pleasure.
My hope is perhaps we won't have to do one of these programs again. But if so, we'll certainly look forward to hearing from you one more time. Next up, we have Dr. Kim Poirier-Schmidt. Dr. Poirier-Schmidt is an assistant clinical professor at SUNY College of Optometry. She works with our students and residents and sees patients in our retina and electrodiagnostics and glaucoma clinics, as well as our primary care clinic. Dr. Poirier is also the instructor of record of our, what is essentially our retina course. And she's been with us at previous programs to discuss with us COVID and the eye. So I will hand it over to Dr. Poirier-Schmidt.
Hi, everybody. Let me just share my screen here.
And just so everyone knows, what we're going to do today, and I should have said this in the beginning, is just kind of share a quick snippet of what our speakers look like in live, since there is this disconnection of having to do CE from a distance. It's not your traditional format. So we're going to have our speakers just kind of show their faces in the beginning, say a little hello, and then they'll turn off their camera once their presentation starts. So thank you, Dr. Poirier, for joining us tonight. All right.
No problem. Hi, goodbye, everybody. All right, so I'm going to move on with an update in the ocular manifestations of COVID-19. And just as a little bit of review, sorry, if you guys were able to listen in on our previous few sessions for COVID-19, it's kind of a little bit of review of what we went over for the previous ocular manifestations. A lot has kind of come about since our last COVID session in May of 2020. The ocular manifestations at that time were known to be conjunctivitis, mostly, typically in our more ill patients that had respiratory symptoms. Conjunctival hyperemia, chemosis, and epiphora were all very common, and we've discussed these in the last three sessions as well, ad nauseum almost. But these are definitely still ocular manifestations of COVID-19 to be looking out for. Also, we discussed possible transmission via conjunctiva and also tear secretions or ocular secretions. So what we did find, or what the studies have shown so far, and again, there still is a lot of studies being performed and a lot of research being done on their low abundance of the virus in the tear and conjunctival secretions. So really, there is a low risk of virus transmission through our ocular secretions, through the tears specifically. However, all the studies have shown that the risk cannot be completely ruled out. So this has kind of been showing that the tears and ocular secretions have a low risk of transmitting the virus. However, the eye still remains a mode of transmission, right? So if you have a patient sitting in front of you that's not wearing a mask, or say you don't have a slit lamp shield and they have a COVID infection, or they have a high viral load, and their spit droplets can actually go into your eye, and that could be a mode of transmission there. So still making sure we're using eye protection. A lot of us at SUNY wear either the face shields or goggles, making sure you're using the slit lamp shield or BIO shields, just making sure you're protecting your eyes, because that is still a mode of transmission. Also, we discussed COVID-19 in children, so the pediatric multisystem inflammatory syndrome, where we found conjunctivitis with possible limbal sparing to be quite common in the few cases that were shown at that time. And also we learned that children can become very sick from COVID-19, especially those with underlying comorbidities. This is becoming even more and more important to recognize, because as our kids are going back to school, right? So just because they're small, they still can become very sick, and they can also transmit the disease to other family members or anyone they come in contact with. All right, so now we're going to kind of move from what we discussed last time into the new kind of ocular manifestations that have been documented over the past few months. And there actually have been quite a few changes or quite a few findings since the last time I spoke with you all. So this is the kind of the more interesting stuff to me. I love retina, so this is a lot of retinal findings. So I'm excited to bring this information to you guys. All right, so what do we know about the SARS-CoV-2 virus? So we know that the SARS-CoV-2 virus, it binds to the ACE2 receptors in the body. And typically these ACE2 receptors, the density is extremely high, in particular in the endothelial cell linings of the veins and arteries. So that also includes the venules and arterioles of the eye, right? So it does really have a high concentration of ACE2 receptors throughout the body, especially in the respiratory tract, but we definitely have a high density of these receptors in our veins and arteries. So the SARS-CoV-2 binding to these ACE2 receptors allows the ability to produce a systemic endothelial dysfunction. So endothelial dysfunction within the arteries and the veins, and especially what we're interested is this endothelial cell dysfunction in the eye. Right, so this endothelial cell dysfunction, it causes vasoconstriction, right? Because the body is trying to auto-regulate, right? Then this can also cause ischemia. So in the eye, we can see causes of this vasoconstriction and ischemia. It's cotton wool spots, also some retinal ischemia, tissue edema. So if the endothelial cells become dysfunctional within the arteries and the veins of the eye, they can also start to leak, right? So we can get tissue edema, not only in the eye, but also in the rest of the body. And also a hypercoagulable state can occur in these patients. Dr. Beaton also discussed with you all the cytokine storm. Well, the cytokine storm can also produce this hyperinflammatory state, not only in the body, but also in the eye. And as you can imagine, having a hyperinflammatory, hypercoagulable state and also endothelial dysfunction can cause a whole host of different ocular manifestations. The ones I'm going to talk to about you guys today are these four in particular. And of course, these are the ones that have currently been documented in the literature. with respect to hyperinflammatory and hypercoagulable states. So microangiopathy, so it's like cotton mole spots, intraretinal hemorrhages, retinal vein occlusions, artery occlusions, and retinal vasculitis. And all of these ocular manifestations that we see within the retina specifically, have also been shown to be caused by both these hypercoagulable states, the endothelial cell dysfunction, and the hyperinflammatory state caused by this cytokine storm. So for microangiopathy, this study literally came out, I think, the day after we had our COVID Part 3 update. So this study was fresh at that time, so I just missed it in our last COVID update. But this study was published in May of 2020, and it was a study in Lancet. And this was the first study to actually show, or they claim to have shown, retinal findings in patients with COVID-19. So it was a fairly small study. So they had 12 patients, all with COVID-19. So they all did test positive, PCR positive for COVID-19. And these patients, the age range, they were kind of on the younger side. They were with their mid-20s to their early 60s. And most of the patients had kind of mild symptoms, and they range from mild to asymptomatic patients. All of these patients had OCT scans all taken about 11 to 33 days after the onset of their COVID-19 symptoms. And just as a note, when they did all these OCTs on these patients were not symptomatic at the time of the testing. So they had already been symptomatic, and whenever the few weeks afterwards, these OCTs were taken. So the patients were no longer sick at that time. So what the authors found is they found these hyperreflective lesions at the ganglion cell layer and the interplexiform layer in all of the patients, so in all of the 12 patients and in both eyes. And they also found in 5 patients to have retinal microangiopathy, or cotton mole spots, and little microhemorrhages. I'm going to show you some images from this study here. And these are images A through D. They're all from different patients. So 4 patients were illustrated here. And this first patient, patient A, this is denoting like a tiny little cotton wool spot. So they claimed also this teeny tiny little microhemorrhage. It's so small, you can barely see it. But in the red-free photo, it's definitely easier to see here, and then the little microhemorrhage there. So they did say that 5 of the patients did have this microangiopathy. However, they only showed photos for 1 patient. So we really only had photo documentation of this one particular patient in that study. And in B, C, and D, these 3 different patients, this is just illustrating these little areas of hyperreflectivity in the ganglion cell layer and within the IPL. You can see them where all the arrows are pointing here. And it was found in all patients. Right, so that was kind of the conclusion of the study. They thought, okay, this is the first time that there was any retinal findings documented in patients that had COVID-19 disease. And they also said that a microangiopathy in the form of cotton mole spots and microhemorrhages could also be found in these patients, potentially. All right, so flash forward to a few months later, so in July of 2020. So this was an article that was in Nature at the beginning of July. And there were concerns, the paper was noted to be concerns about interpretation of OCT and fundus findings in COVID-19 patients in recent Lancet publications. So this was kind of a direct refute, so to speak, of the findings that were in that Lancet article. So they had noted is that the Lancet article denoted these hyperreflective bands. They were interpreted to be as abnormal, but they had normal OCTAs. So OCTA was also, or OCT angiography was ran on these patients, these 12 patients as well, and that was completely normal. So you would expect if there's some sort of microangiopathy or some areas of ischemia, then the OCTA would also be affected or show areas of capillary non-perfusion or abnormalities in those areas where those hyperreflective bands were. But what they found is that it was normal. So the authors of this Nature study were saying, well, if these hyperreflective bands are abnormal, then why is the OCTA normal? So they just felt like that did not match up properly. What they also found was the OCT findings, they bear significant resemblance to normal intraretinal vessels. So they were saying, you know, this group here in the Nature article was saying that, you know, actually these OCT findings were normal, and which also would explain why it was found in all of the patients that they did scans in. And they also noted that cotton wool spots were noted in multiple patients. However, the one illustration, the one lesion illustrated may actually represent nerve fiber layer myelination. I'm just going to show you this again. So this little area here, how it, this tiny little area, they said it could possibly be nerve fiber layer myelination, but who knows? I think really what they need to do is follow these patients up and re-image them, right? Because if it's a cotton wool spot, it should go away on its own in about a month or 1 to 3 months. And if it stays, then it's nerve fiber layer myelination. So the authors of this Nature study were kind of refuting the findings in that Lancet study. So more studies needed to be done, and more, you know, case studies needed to be shown in order to prove the point that microangiopathy can be seen in the retinas of some patients that were infected with COVID-19. All right, so let's flash, oh, sorry, I missed this slide. So this is actually the OCT scans from the Nature article. We're just trying to show that these hyperreflective areas are actually found in normal patients. So this is the exact same kind of hyperreflective areas that were found in a normal retinal scan. So they were saying that these are just kind of the superficial arteries and veins that are being imaged here, and not actually areas that were abnormal. You can see that they're actually very similar in appearance to these OCTs in these COVID-19 patients. All right, so now flash forward to about a month later, so the end of July. So at the end of July, a group out of Spain, I believe, came up with another study of COVID-19 retinal microangiopathy, and as an in vivo biomarker of systemic vascular disease. So this study, they evaluated 27 COVID-19 positive patients, and they evaluated them 14 days after discharge from hospital. So when they were discharged, the patients were no longer ill and they were asymptomatic at that time. At the exam, DFE, fundus photography, OCT, and OCT angiography was performed. And what they found was that 5 patients had unilateral cotton wool spots and 1 patient had bilateral cotton wool spots at presentation or during this exam. So they concluded about 22% of the patients in the study did actually have signs of retinal microangiopathy manifested as cotton wool spots. So what the authors had postulated was that possibly these areas of focal ischemia or infarcts of the nerve fiber layer could have been caused by direct infection from the SARS-CoV-2 virus, or this is causing endothelial cell dysfunction, or could also be secondary to a hypercoagulable state. They weren't 100% sure. So this is I'm going to show you 2 different photos from 2 patients out of that study. You can see this is a 45-year-old female, and this is the one with the bilateral cotton wool spots. And you can see the white arrows here denoting where these cotton wool spots were. And then we also have the corresponding OCTs through the areas that had the cotton wool spots. And you can see the nerve fiber layer is definitely swollen here, here, and here, where those little yellow stars are. So the patient definitely had bilateral cotton wool spots, and all of these patients as well were worked up for other systemic causes of cotton wool spots. Of course, you know, there are many different systemic diseases that can cause cotton wool spots, and all of these patients were worked up very vigorously for other systemic disease, and they were negative for everything. So really, the authors were attributing this to a COVID-19 or recent COVID-19 infection. This again is another example of a 69-year-old male. He had unilateral cotton wool spots, so in the right eye only. You can see over here in this photo, this little cotton wool spot here. See, it's nice white and fluffy, very superficial. You can't see any of the blood vessels underneath. So we know that's a cotton wool spot there. Also, if you took an OCT through that, again, it's actually a slice from an OCTA. However, you see that the nerve fiber layer is very swollen, so very kind of superficial part of the retina, just correlating to that cotton wool spot. And again, the OCTA was performed through that area, and you can see this kind of darkened area, which is correlating to area of ischemia on the OCTA. All right, so what does all this mean, right? So we know that these patients can present with microangiopathy or signs of damage to the retinal arterioles or veins. But what does that mean for their patients, right? So what this group hypothesized is that fundoscopic evaluation might actually help to identify patients with signs of arterial microangiopathy. So we always say, you know, the eyes are the window to the soul, right? So what's happening in the eye is happening in the rest of the body. So these authors said, okay, so if there's signs of microangiopathy in the eyes, there could also be signs of arterial or venual microangiopathy in the rest of the body. So maybe these patients need to be treated. So either with heparin or some sort of anti-aggregation therapy. So the authors said that fundoscopic evaluation of COVID-19 patients upon admission to the hospital could be indicated. Could be another screening, right? So instead of doing a full gamut workup, you know, just dilate the patient, take a look at the fundus. Do they have any signs of retinopathy or microangiopathy? And if they do, maybe consider anti-aggregation therapy. So whether these patients would benefit from this therapy requires further investigation. And I know Dr. Beaton had discussed, you know, a lot of these patients upon admission to the hospital actually already are just given heparin or already pre-treated. So this might not even be, you know, might not even be necessary, where a lot of patients are already being treated regardless when they're upon entering to the hospital. But again, you know, if you're seeing patients who have previously had this COVID-19 infection, you know, I know we have a bunch. I had three patients last week who all had COVID over the past few months, and they're asymptomatic now, but these are the things we should be looking for in patients, because these types of retinopathies tend to be seen after they have the actual active infection. So things to be looking out for in our patients. All right, so this is another example of a case study of a patient with CRVO. So this was actually a very young patient. He was 40 years old, 40-year-old male. He presented to this specific clinic with the entering complaint of like an enlarged blind spot in his left eye. So the patient was relatively, you know, healthy, really had no other systemic conditions. The most pertinent information, though, is that he did have a previous COVID infection about 3 weeks prior to the onset of his ocular symptoms. They dilated the patient, and this is what they saw. Right? So it's the left eye, of course, and the optic nerve is very edematous, a lot of exudation, cotton wool spots. So the papillitis, right, or inflammation of the optic nerve. When you have that much inflammation of the optic nerve, it can cause a lot of pressure and push down on the central retinal vein, and it actually can cause a central retinal vein occlusion. And so that's what happened in this patient here. Fundus photo here, and actually the fluorescein angiography on the right-hand side here. You can see a lot of leakage from the optic nerve here, as well as some staining of the venules. So maybe a possible little bit of a vasculitis as well. And this is an OCT scan, you know, through the nerve and towards the macula. You can see a lot of edema, a lot of swelling of the optic nerve here, and then some intraretinal fluid kind of going towards the macula. At this point in time when the patient presented, he actually had pretty good vision. You know, he was 20/20 because this fluid actually hadn't reached the macula yet. But since the optic nerve was so swollen, he did have an enlarged blind spot as well. And his vision was actually pretty good. So what they decided to do at this point in time is to do an extensive workup, right? He's a young guy with a papillitis and a central retinal vein occlusion. So they did, full blood workup to rule out infectious, inflammatory, autoimmune, hypercoagulable states, and really everything came back normal. And so all the blood work, he had probably every blood test known to mankind performed on him. So really what it came down to is them attributing the inflammation of the optic nerve and subsequent CRVO from the hyperinflammatory state, likely caused from that cytokine storm from the previous COVID infection. So they also, not only did they work him up systemically, right, but they had to treat him ocularly. We can't just leave his eye like this, right? So they referred him to a retina specialist. So this is the follow-up exam here. We can see that his vision was much, much worse. This is about a week later, I believe. And you can see that the macula is now extremely edematous. The vision, I believe, was down to 2200. So very, very decreased, a lot of swelling. So a lot of that swelling that came from the nerve finally kind of reached the macula at that point. So what they ended up doing, as what Dr. Beaton was discussing earlier, one of the treatments for this cytokine storm is dexamethasone, right? So what they ended up doing is actually injecting a sustained release dexamethasone implant into that left eye. And you can see the bottom pictures here are 2 weeks after injecting that implant. So the eye responded very well to the steroid, right? So you can see the papillitis has greatly decreased. Also, the macular edema has significantly decreased. So the authors, postulated that this papillitis and the CRVO and all that inflammation was actually secondary to the COVID cytokine storm, and also kind of proves that the fact that the eye responded so well to the steroid also kind of goes towards the underlying inflammatory cause of the vein occlusion and the papillitis. It's an interesting case. So, if you see a patient with a CRVO, consider COVID, a previous COVID infection, as a differential, right? So include COVID testing in your workup for these patients with vein occlusions. Okay, so moving on to another case of a 60-year-old male. And the 60-year-old male was presented to the emergency room with severe respiratory distress. He also had a high fever. He was tested for COVID and he tested positive for COVID-19. He developed acute respiratory distress syndrome. So he actually ended up having to be intubated and then was admitted into the hospital and intubated. Around the 12th day of him being in the ICU, he developed acute onset of vision loss in his left eye. So the ophthalmology consult was called. They came to the ICU. When they dilated the patient, they noticed that the patient had, kind of edematous retina, very whitened retina, and also with a cherry red spot in the macula. So they diagnosed this patient with a CRAO. Of course, when you have a CRAO, you want to consider many different causes of a CRAO. You always want to rule out GCA, right, which they did. They ordered a host of blood work. They ruled out GCA, so his ESR and CRP were completely normal. They did other full workup. He's positive for hyperlipidemia and hypertension. So, he did have comorbidities. So it is possible that he could have had an artery occlusion from, his other comorbidities. However, the authors did kind of postulate that it was likely secondary to a hypercoagulable state. So of course, when the blood is really thick and drudgy, it can block up the central retinal artery and can cause a CRAO. So of course, it's vision loss, and this poor patient, of course, lost their vision and did not regain any vision in that left eye. And just to make a note as well, so we know that CRAOs or artery occlusions, also BRAOs and BRVOs could also be possible. However, there's not really much in the literature at this point in time of BRVOs and BRAOs being caused by COVID-19. But however, the underlying pathophysiology is there. So it's very possible. They just have not been documented in the literature as of yet. So if any of you guys have any BRVOs or BRAOs caused by, caused by COVID-19, definitely just go ahead and publish it. So just a reminder as well what an old CRAO looks like. So if you have a patient that has had a COVID infection a few months prior, they come in with an old CRAO, right? So maybe they said, their vision decreased or they lost vision suddenly a few months ago. It usually takes a little longer to get this appearance, but an optic nerve head pallor with this sclerosed vessels. And also you have really atrophic inner retina. So if you do an OCT through the retina, the whole inner retina will be atrophic. So just keep in mind, old CRAOs, new CRAOs, or fresh acute CRAOs also include COVID-19 in your workup for these patients. Okay, so moving on to retinal vasculitis, this is actually a really interesting case of a pediatric patient. So this is an 11-year-old boy in Spain. He actually presented to the dermatology emergency room. So yes, they have an emergency room for dermatology in Spain. Who knew? And we might have them here, but I've never heard of that before. But he presented with these kind of red edematous plaques on his toes. And the dermatologist, I was asking the COVID questions. He was not around anyone who was ill. He has not felt ill. He didn't have a fever, didn't have any signs or symptoms of COVID. He was being very careful to make sure that, he wasn't around anyone who was ill. And so they included in his workup COVID testing. So the COVID testing came back actually positive for IgG antibodies. So he did have, a recent infection, right? So IgG is the immune antibody that's produced later on, right? So it's a previous infection. The IgG is high, and the IgG was high in this patient. So the doctors that saw this patient, they're really smart to know that, this signs on his toes could also indicate a thromboembolic event. And they also knew that that could happen in the rest of the body, right? If they're seeing it on his toes. So that part of his workup, they actually sent him to ophthalmology to have the retina, take a look at the retina to see if there's any signs of any microvasculopathy or microangiopathy. When they dilated him, what they found was that he had these little tiny areas of vasculitis. Kind of hard to see here, but there's an artery here, and all around it you have this exudative material. So a bit of a vasculitis far periphery of that left eye. And the patient was asymptomatic completely, and also has some cotton wool spots out here, so maybe a little bit of retinitis out in the periphery. So this was actually the first, and to my knowledge, the only documented case of a retinal vasculitis with a patient that had a previous exposure to COVID-19. So kind of take it as you will. If you see any patients with vasculitis, definitely consider COVID-19 in your workup as well. So testing, definitely COVID testing in those patients. And I know we actually had a patient at SUNY recently. I think they did a presentation on this patient at Grand Rounds actually this past week. And this patient is a young kid, has a bilateral, looks like to be a possible vasculitis, asymmetric between the eyes, and they're going to consider COVID-19 or COVID testing in the child's workup as well. So be on the lookout for any vasculitis in your patients. All right, so kind of moving on from our retinal findings. So there were only a few kind of neuro-ophthalmological findings or manifestations noted. So this is a kind of very recently came out in August of 2020. There's a case study, and 2 patients presented with a chief complaint of diplopia. And both of these patients had recent infection of COVID-19 a few weeks prior, but now they weren't symptomatic for COVID-19. However, they were now presenting with a new onset of diplopia. Without getting into too much of the neuro stuff, so just for time's sake, if you guys have any extra questions, you can always ask me. But the authors of this study, they diagnosed patient number 1 with Miller-Fisher syndrome. So Miller-Fisher syndrome is typically a syndrome with the ophthalmoplegia, so an INOs, also with areflexia or ataxia. It's typically after a viral infection this is found. So with this patient, they found consistent findings of a right INO and a right fascicular ocular motor palsy. And then also he had areflexia, so loss of deep tendon reflexes, and also ataxia, so just really uncoordinated movements. Patient number 2, they diagnosed with polyneuritis cranialis. And this patient had findings consistent with a bilateral abducens palsy and also had loss of the deep tendon reflexes as well. So the authors postulated is that these neuro-ophthalmological manifestations could be due to an inaccurate immune response to SARS-CoV-2. So it's almost like an immune-mediated injury within the oculomotor pathways of these patients. So again, this is just 2 patients. It's very recent, but just be on the lookout for patients who have recent onset diplopia and have also had a recent COVID-19 infection, just to make sure that you consider COVID in your workup for any patients who have had recent onset of diplopia. So just something else to consider. Of course, this is really the only one that has been documented. However, I'm sure as time goes by, there probably will be more neuro-ophthalmological manifestations secondary to COVID infection. So stay tuned for that. Okay, so some other non-infectious ocular manifestations. One of the big ones is exposure keratopathy. And I'm sure a lot of you, if you've had patients that did have COVID or were hospitalized for a long period of time, they may have developed exposure keratopathy. So really these patients have reduced blink reflex and drying effects due to the high oxygen flow. So these patients are in the ICU, they have wearing oxygen masks, high oxygen flow, or even intubated. That air can be pushed to the eyes and cause exposure keratopathy. This is really mostly seen in patients with more severe course of the disease, and they're usually or typically in the ICU. So you may see these patients after, if they're lucky to be discharged and get better, or if you're working in a hospital setting, you may need to do different floor consults or ICU consults. That exposure keratopathy definitely is very prevalent in any patient really in ICU that's on oxygen. All right, that was a lot of new ocular manifestations. So just in review or conclusion, so the ones we went over today, ocular manifestations secondary to hyperinflammatory or hypocoagulable states, so microangiopathies, cotton wool spots, hemes, vein and artery occlusions. Again, really in the literature, we're only seeing CRAOs and CRVOs here. However, I'm sure just with the underlying pathophysiology that BRAOs and BRVOs are also could be ocular manifestation of COVID-19. Just there is not a lot in the literature right now. And also vasculitis. So be on the lookout for these conditions. If the patient does have COVID or had previous COVID infection, make sure you're dilating your patients, doing fundus photos, making sure you're looking for these types of ocular manifestations. Or if you see a vein occlusion, artery occlusion, or an unknown cotton wool spot or hemes or vasculitis, just make sure you include COVID testing in your workup of these patients or your systemic workups. Also, the 2 cases of Miller-Fisher syndrome and polyneuritis cranialis that were just recently documented. So again, there's only these 2 cases. I'm sure as time goes on, there may be more. But if you have a patient that presents with a recent onset diplopia, again, consider previous COVID or current COVID infection as a possible underlying cause of their neuro-ophthalmological manifestations. And also, if you have patients that were inpatients, typically in the ICU, ocular surface disease is very, very common in exposure keratopathy. So making sure we're looking for exposure keratopathy or ocular surface disease in these patients is crucial. All right. That's
Thank
it.
you so much for that, Dr.
Dr. Poirier, there was a question about, I believe it was the Lancet article, and we probably should just address it right here.
Yeah, sure.
And it was, the question says, are there before and as well after COVID OCTs? And I think maybe you might have touched on that. And then the question that followed that was, did these 12 patients have hypertension and or diabetes?
Right. So the first question is that the Lancet study only did the one OCT scan. They did not have any follow-up scans over time on these patients, which was also kind of a problematic point of the study, is that they didn't have any follow-up for these patients to look for any change or consistency over time. Also, in the second part of the question was, do the patients have hypertension or diabetes?
Yeah,
actually,
I'm sorry.
yeah, that's okay. So actually, most of these patients, they were younger. They didn't really have a great cohort of patients, and most of them were actually healthy. So they didn't have a lot of comorbidities. So that's why the authors were saying, we're able to attribute these findings to, COVID-19, and they're relatively healthy patients.
Yeah, just to comment on the image too. You had the cotton wool spot, and at least one of the OCT images, it looked like there was a little bit of a wedge defect sitting just above the cotton wool spot. And you do see that with cotton wool spots. I've certainly seen that in patients who've had HIV microangiopathy, and also in patients with interferon retinopathy. And so you can imagine a time 10 years down the road after patients, and hopefully if this is long in the rearview mirror, where we start to see these patients who have these wedge defects and they're worked up for glaucoma as opposed to just have something that's occurred, from a past infection. So that was an interesting image.
Yeah, definitely. And a lot of the time, you're welcome. I was saying a lot of these studies actually were comparing a lot of the microangiopathies to HIV microangiopathy, like very similar, underlying pathophysiology.
That's exactly what it looks like. I'm old enough to be around when HIV was, when we saw a lot of patients with HIV, and patients who didn't have full-blown AIDS would often present with HIV retinopathy, which was just marked by lots of cotton wool spots.
Yep, exactly.
Thank you. Hang on there. Maybe one more. We might as well hit the questions. Oh, yes. Yeah, this was, when you order COVID testing in patients who present with ocular findings, would you order antibody test or PCR?
That's actually a really interesting question. So, I mean, I personally have not done that yet because I haven't really come across these findings myself, but now kind of looking forward, I mean, obviously a rapid test would be great. I mean, you could probably order both I would actually order both the antibody test and the COVID-19 PCR testing, because you want to know, maybe they might not have a current infection, but a lot of these retinal findings were actually found after they were when they were asymptomatic after the fact. So antibody tests, I think, could be helpful in kind of nailing down if a patient had a previous infection.
I agree. It's an interesting question. Thank you. We need to move on time-wise. So thank you, Dr. Poirier.
You're welcome.
Next up is Dr. Laul. I'll just wait for his slide to come up. And there he is. Dr. Laul has a number of jobs at the college. He sees patients in our primary care and in our glaucoma clinics. He's involved in our teaching labs. He's the presiding officer of our faculty right now. But the reason he's been part of this program is that he is the chair of the Environmental Safety and Infection Control Committee at the college, and has been at the forefront of our response to the virus over the course of the last 6 months. So I will hand it over to Dr. Laul.
Great, thank you so much, Rich. So I'm just going to pull up my slides here in a second, and then yeah, we'll get going here. So you guys should be able to see my slides. Are you good there?
No, I don't see your slides just yet. Let me
okay.
Let me just stop sharing mine, and maybe go ahead, try to show yours now. Dr. Laul, you still there?
Yep, I am. Yep. So it looks like it's, at least on my end, it looks like it's that it's starting to share now. So you should be able to see it in a second.
Okay. No slides
Not
yet.
coming through. I knew I would unshare and then
Sure.
share again.
Will
Sometimes that
do.
happens.
Will do.
This is the world of Zoom now.
Right, exactly. All right.
There we go. Well, we see you now.
All
Okay.
right. So I'm going to start my
Here it comes.
broadcast here.
Yeah, you got
There
it.
we go. Ah, okay.
Fantastic.
All right.
Still no slides yet, but it says you're started sharing.
All right. Yeah, I'm at the college, so you know the internet on the 7th floor here is can be a little bit slow.
If it's anything, just send it to me quickly, and then I will share it on my end, and I'll move the slides for you. So it looks like something's moving, but there's nothing on the screen, unfortunately. So I do apologize to everyone. You know, we're getting it.
Right.
Would it make sense to flip over to Dr. Soden while Dr. Laul
Let's
tries
do
to
that.
get things
Sure.
to work? And
Okay.
then we could just change the order. I think that would be fine.
Yeah, I agree.
So, okay, wait.
So I just stopped share.
Okay, great. Next up is Dr. Richard Soden, if he's there.
Dr. Soden, you're here, right?
There he is. Okay, I just want to make sure. I think we all know Dr. Soden. He's a longtime faculty member at the college. Right now, I mean, he's been involved in the clinics. He's the past president of the New York State Optometric Association. And right now, he really directs our managed care and external programs. And so his official title came up on the screen as the Director of Healthcare Development. That's what I was looking for. So I'm going to hand it over to Dr. Soden, who's just talking about telehealth. As we've mentioned in our previous programs, you know, telehealth has been coming around now for the last few years, but COVID really accelerated the future of telehealth to something that really was with us in a matter of months rather than a matter of years. So I'll hand it over to Dr. Soden.
Okay, Dr. Soden, you got to unmute yourself.
And you're going to stop sharing your screen?
Yes, you can go ahead.
Okay.
Okay, I see your screen.
Okay. And hopefully you see my slides.
I do.
Okay. All right.
All right.
Well, good evening.
All right.
Good evening, everybody, and thank you for joining this. I've discussed telehealth before in previous webinars with you, and I thought I would take just a little bit different stance tonight and just talk about where we think telehealth is going. And virtual health, telehealth is certainly distance interactions to further care, health, and well-being of patients in a connected, coordinated manner. That's actually a great definition of what telehealth is all about. And there is no doubt that telehealth is going to be here. When we go back to the beginning of the COVID epidemic, there were very, very, very few services that were approved for telehealth services. Medicare had very limited capabilities of covering services. It was mostly in rural areas. Medicaid programs throughout this state and other states covered a little part of it, and the fees were absolutely very, very limited and reduced compared to fees of office visits. The coronavirus came. CMS, the Centers for Medicare and Medicaid, temporarily waived a number of these restrictions and adopted some very significant regulatory changes to enable providers of all professions to use telehealth to access their patients. Before the pandemic, only about 14,000 patients received a Medicare telehealth service within a week. And then post-pandemic, they've been estimated that over 10.1 million patients have received telehealth, Medicare telehealth services from mid-March through early July. So there is no doubt that telehealth is here to stay. The Medicare leader, Seema Verma, has actually gone on record in saying, I can't imagine going back. And she calls for an expanded telehealth service after the Corona-19 pandemic is over. If you remember, the way CMS works is every July they come out with a proposed set of guidelines that are going to go into effect the following year. So this year they were a little late. They came out with a lot of these guidelines in August, and they basically have said the genie's out of the bottle. We're going to put the genie back in a little bit, but we're not going to put it back to the level or close the lid as it was before the pandemic. So the current proposal, which is under consideration right now, and the way this works is that all professions, including the American Optometric Association, get to look at these proposed changes, submit comments to CMS, and a final proposal will come out probably in late November, early December. And the proposal that they're putting forth right now, and it involves lots of different services. I'll talk about E&M services as we close this portion. The proposal is to continue home visits for established patients, meaning that providers are going to be able to continue to communicate with their patients, established patients only under the proposed schedule. If you remember, basically, you could do anything you want with new patients and established patients, but they're looking to limit the future of telehealth to possibly only established patients. I think it makes sense in some levels, and I think it's a little myopic and other things, looking forward to not letting a new patient have a telehealth services. They were also going to limit some of the occupational and physical therapy services that were being done or are being done, and some of you may be involved in that in the vision rehabilitation modality. But those are some of the proposed services. They are planning to add a new service for primary medical care, and that pretty much includes optometric services if it goes the way the AOA is proposing it goes. Whereas if you have a complex patient that you're doing telehealth service, you may be able to add an add-on using a new CPT code that is going to be developed, and add on to an additional E&M service or an eye service, depending upon basically where that goes. So I would stay tuned, and when these proposed rules become finalized rules, we can go over them at some future point. As it stands right now, we are still in the middle of the pandemic. All things are still going on. You can basically do synchronous telehealth services for your patients, asynchronous telehealth services for your patients. You can do virtual check-ins for brief visits, e-visits with communicating with the patient via an online portal or a secured email system if that's possible. Telephone services, they could be non-face-to-face services via telephone, audio only, typically defined as asynchronous. And many of these have been reimbursing for services at the same level as if the person was sitting in your office. Telephone services, which were reduced, which paid very, very low rates, have been up dramatically. Where this all goes and what the fee changes are going to be, we have to wait and see. But somewhere down the line, telehealth is going to be a very popular service. It's been estimated that all providers may expect to incorporate telehealth services into their practices at a 20 to 30% level. I've spoken to a lot of eye care providers who actually find that it's going to be an integral part of staying in touch with their patients. It could be used for red eyes, follow-up visits, patients who have questions about some of their current symptoms. And I think it's going to propose or become components of a lot of things going on into your practice. I found some statistics that showed that the Geisinger healthcare plan funded a study that said the implementation of telehealth actually generated about 11% in cost savings for providers and for the healthcare plan. 67% of patients saying that using a telehealth service increased their overall satisfaction with medical care. That's a huge number. And 75% of all doctor's visits were actually recorded to be unnecessary or could be handled safely and effectively over the phone or video. So I think you're going to see lots of changes going on. The COVID pandemic has accelerated virtual healthcare across the healthcare ecosystem for patients, providers, health systems, and health plans. I'm not going to read all of these statements underneath, but 4 main categories of patients that, or people that use the healthcare system: patients, providers, health systems, and health plans have readily adopted it. More patients than ever have received care virtually during the pandemic. Pre-pandemic, it may have been 17%. It shot up to almost 21%. There's a 2 times consumer adoption, whereas it was very, very limited prior to the pandemic. And 4 out of 5 consumers indicated they're likely to continue using virtual healthcare services, which is a large number of individuals. Providers who are not willing to or slow to adopt to telehealth services or virtual healthcare services pre-COVID have been supportive of this. They find interesting ways of doing it. Basically, you can use all the different kinds of codes that exist right now, and you can deal with some challenges of seeing patients who may not be able to come to your office. And they're also looking at how to incorporate this into their future practice. Healthcare systems are really embracing this. They're enabled to improve efficiency, coordination, clinical care outcomes. Studies are being done. There are still some challenges: interoperability, workforce changes, consistency, and health plans are covering a very wide variety. Pre-COVID, there were very limited CPT codes. Basically now CMS and many healthcare providers have expanded them, including the ability to do a comprehensive eye exam if you could figure out how to do that, and your documentation would support what's going on. States are anxious to use these. Patients who can't get out of their homes, people who can't get to doctor's office because of numerous reasons, discussions of food insecurities. All of these are absolutely being used for telehealth services. And I think optometry can actually start to figure out how best to use some of these services. We're gonna have to see what the final rules are. We're gonna have to see what the reimbursement rates are, but I think it's going to be much more positive and much more favorable to the level, beyond the level that it was before the before the COVID pandemic happened. The other major change, and I'm going to close on this in the next slide, is that there is going to be a huge change in E&M coding that takes place as of January 1st, 2021. So we're about 4 months from now. And there was some doubt whether or not that CMS was going to continue with this or actually put this project on hold. But they confirmed back in July or beginning of August that this major change in E&M coding is going to take place. Hasn't happened for 25 years. And with that, there are going to be significant swings to the Medicare pay rates and probably to other insurance carriers too, as the changes are finalized. This all came out in the proposed rule. They are talking about an 11% fee cut to physicians' fee schedules based on a conversion factor that they use. And it's a little too late and a little too beyond this to go into that right now. But basically, in order to increase the level of office visit E&M coding, which is really what they want to do, they want more money to go to you for managing your patients, including optometric services. They're going to maintain budget neutrality by cutting back on procedures like eye examination codes, possibly procedures such as visual fields, OCT, they're going to cut the reimbursement on those and increase the reimbursement for office visits. The entire coding system is changing. It is going to be a very, very easier way. They're basically doing away with the counting of history and examination, and they're basically going to be using time in medical decision making. And I think it's important for every optometrist to really start to think about how they're going to implement this monumental change. I've lectured on coding and billing for decades, and I've always said 9,200 codes are probably the way to go. But I'm going to tell you that from what I'm reading right now, as of January, I would go with the 9,900 codes. I am going to be presenting at the Envision program about an hour and a half lecture on these changes, and I would urge anybody to really, I would urge everybody to learn about this and understand what's going on. So telehealth is here to change, and be prepared for the E&M services, because you're going to be using those to manage patients with telehealth as well. And good luck with everybody. And if you have any questions, I'm happy to answer them, or you can email them to me.
Thank you, Dr. Soden. I really appreciate you taking the time. Okay, we're going to try this again. Dr. Laul, you there?
Yep, I'm here. So I'm on the 14th floor. So hopefully this will work out.
Okay, we have a plan B. Just let it be.
Okay, all right.
Go ahead and start sharing your screen. Oh, I see a screen.
So is it working?
It's a screen. It's your.
All right, perfect. Fantastic. So let's go ahead here. COVID in the community. Let's get this going. So I guess the internet is much better here on the 14th floor.
Yeah, it also depends on if anyone here knows SUNY. It also depends on what part of the building you're on, whether you're in the back, in the middle of the building. It's your service.
Right, exactly. All righty.
All right,
well, thank you for but thank you for bearing with us here. So really what I'm going to be chatting about today is just sort of updates on some of the cleaning protocols, a little chat about airflow, facial coverings, and lastly, just the CDC update on eye protection. Now, the last time we did this presentation, that was in May. And, one of the things that the questions that really popped up was in regards to tonometry. So that being said, I'm going to revisit tonometry again and hopefully clear up some of the things that I didn't get a chance to clear up back in May. I do apologize for anybody who is at SUNY, because I've lectured about this ad nauseum. But really what I'm going to be talking about here is that there was a paper that came out in June of this year done by the group at Columbia. So Jack Coffey, Liebman, and one of our consulting ophthalmologists, Dr. Moraes. This paper, of course, really focuses on glaucoma care. So it talks about cleaning protocols for things like your visual field, your OCTs, and also just a basic room cleaning protocol. For information on a room cleaning protocol, one of my last slides, I'll show you where resources on room cleaning protocols are at. But again, like I said, I did want to focus a little bit on tonometry and then kind of tell you what's going on. In this particular study, what was really great is that they'd had tables on how to clean your different types of visual fields, different types of OCTs, and as you can imagine, different types of tonometry probes. So from this diagram, you can see that it talks about the Hog tonometer probes, the Goldman probes, the eye care, some of the right carts like the TonoPen, and even the air puff tonometers, and lastly the Keelers. I am going to focus a little bit on just the Goldman probes, and as you can see from the Goldman probes, this is the correct sort of solutions to clean off your Goldman probes. As you can see here, things like alcohol, although it's very effective in getting rid of the coronavirus, due to other reasons, i.e. damage that it can do to the actual tonometer probes themselves, the plastic and the glue of the tonometer probes, it does not recommend alcohol as a cleaning solution. What they do recommend is either a peroxide solution or a 10% bleach solution, and that goes both for the Hogs and also the Keeler probes. One thing to note is that when it comes to eye care, although the disposable probes are obviously changed between patients, but make sure that you also clean off the actual handheld itself. So I do use alcohol to clean off the handheld between each patient as well, because as you can imagine, you're getting pretty close to a patient. A patient can breathe on it. You might even feel the breath on your hands or gloves. So you do want to clean that off between patients, again, as a vector of spread. The cleaning protocol, in case you are not familiar with it, we have this now on all of our clinic floors, and this is what every single floor is doing, that we have technicians and staff members, so front desk members or office managers, perform this type of cleaning protocols. So just as a heads up, if you're interested in the cleaning protocol, it's a rinse for about a minute, soak in the solution, so whether it be a peroxide solution or a bleach solution for 10 minutes, another rinse for in between 10 and 30 minutes, and then dry. We have actually these little strainers, a red color strainer for dirty probes and a green color strainer for clean probes as part of our cleaning protocols. And this is being done at the college, as of right now. In terms of non-contact tonometry, because I still get asked about non-contact tonometry as well, this study talks about the initial hesitation for non-contact tonometry was based on a 1991 study. And this 1991 study, it's kind of a misnomer actually in the actual study name itself. So I'm going to show you this study here. So the study says that it's a microaerosol formation in non-contact air puff tonometry, but actually in this study, they did not look for microaerosols. Really what they did was they went ahead and put in some fluorescein dye in a patient's eye, and then using that keeler pulsar non-contact tonometer, you can actually see by slow, from a slow motion camera, that this is an eye before, and then this is an eye during the procedure itself, and this is the eye after. So as you can see, as that air puff hits the front surface of the eyes, we are getting a lot of splatter of tears. And even after the procedure is done, you can actually see that there is some splatter on the patient's nose, on their eyelids, on their cheek as well. And as Dr. Poirier mentioned, the tears could be a source of, although a low source of the coronavirus, it has been shown using PCR testing that there is coronavirus particles within that tear film itself. So when we look at that actual report, really what it says here is that, unless we can truly prove that we're getting aerosolization, at this stage of the game, you really should look at that risk-benefit ratio. So in cases where you need to do non-contact tonometry, you can do it, but just be mindful of it. Can microaerosol formation occur? There is a recent study at Owenza Medical University, and for some of you know that's one of the universities that we do send our students to. We have a relationship with them. And they did a recent study on, I think this came out in August actually. So I think they did a study on, they used actually an air purifying purifying detector to see if there was some microaerosol formation pre and post using a non-contact tonometer. And really what they found here is that with repeated uses in a closed environment, and you're looking at really small particles, they test particles of the size of 10 microns and 2.5 microns, that there was an increase in small particles. As you can imagine, if the patient was wearing a mask, there's less particles versus if the patient was not wearing a mask. So that does tell us that I think a lot of microaerosol formation are really coming from our nose and mouth, and that's why masks are important. I'm going to talk about masks here in a moment, but there is some evidence that there could be some microaerosol formation using a non-contact tonometer. However, I think further studies really need to happen. But that really brings us to the point of airflow, because in this article, it talks about doing the test in a small room versus in a hallway, and it talks a little bit about airflow and finds that areas with more airflow, there is actually less detection of these microaerosol bodies. So that tells us the airflow is very important. And I think that we know that airflow is something that is so important. A lot of us have probably seen this diagram months ago. It was in the New York Times and other publications talking about a person who is in a restaurant, that's A1 right there, in a restaurant, in a Chinese restaurant with poor ventilation, no open windows or anything like that. And you can see over the course of days that people in the adjacent tables, so on the same table, but also the adjacent tables, have contracted the disease. And what it showed is that you can see here that this air conditioning was really pushing air back and forth, and there was no ventilation. Hence, I think the average time was about 70 some odd minutes of overlap. And you can imagine that folks did get infected with the disease. So we know that this is a respiratory virus, and airflow does play a role. How much of a role? That's again, it's rather interesting. I think we need a lot more studies. The only reason I put this study up because I really like the diagrams of this study. So as you can see here, it talks about large particles. And sources of transmission can occur essentially from self-inoculation with contacts of droplets. So these are these large particles that either A, settle on surfaces, and then you direct deposit via your hands or such, or from direct deposition through your mouth and nose from someone who is talking. How much is how much do you get if you're just inhaling aerosols from the room versus droplets? That's actually somewhat controversial. So you can see from this here, long-range transmission of viral respiratory pathogens, including influenza and coronavirus, still remains controversial. So, how much of this is related to aerosols within a room versus true droplets? I think we all understand that droplets are probably the major vector of the disease. What's the difference between a droplet and an aerosol? It really just comes down to size. So as you can see, droplets from anywhere from 100 microns to just under, less than 10 microns. Once you're getting to less than 10 microns, we're getting this conversion to aerosolization. The COVID, the SARS-CoV-2 virus is actually very, very small. However, is the COVID-2 virus floating around in the air on its own? Again, we're not sure, and probably not. It's more likely in a droplet form or an aerosol form. So as you can see here, an aerosol, which is 2.5 microns, can contain hundreds of COVID-2 or SARS-CoV-2 virus. What this diagram shows us is that, of course, the bigger the molecule, the more likely it was to fall to the floor, right? So less time suspended. So something that is very large, within seconds, let me go back here, within seconds, it falls to the floor, where something that's very small can actually stay suspended in air for hours. This article just talks about air exchange. So that's with this here. So your air exchange per hour, and the higher the air exchange per hour rate, the better. When it comes to hospital rooms, for example, the air exchange rate is actually quite high, about 6 times per hour. If we're in an operating room, the air exchange rate is even higher. It's actually about 15 air exchanges per hour. And at least 2 or 3 of those has to be via fresh outdoor air, so outside air. So it is one of these things where airflow really does play a role. And that's something that we're being a little more mindful of here at the college. So that being said, what things can we do to improve airflow? So open windows if possible, introduce more outside air. This is something that we're doing at the college, where we're in an HVAC upgrade at this point, and we are introducing more outside air to our HVAC system. That does make things a little difficult, because as you can imagine, if you're introducing outside air, it's harder to cool that air In the winter, it's going to be harder to warm that air. So if you are introducing a lot more inside air, it's harder to regulate the air within the building, but it is something that we are doing. Other things that you may want to consider, and these are things that I've talked about here in the past, things like streamlining your examination, keeping exam doors open, or if you're in a practice where you can actually keep the front door open so that airflow is coming into your practice, that might be something that you can consider. Consider splitting up your examination. So, my glaucoma patients, I may see them for an IOP check and say, you know what, I want you to come back in a month or so to get a visual field done, so that they come in and out just for that visual field, so they're not spending a huge amount of time within our clinic spaces. And then last thing, of course, don't crowd common spaces and try to maintain social distance when in an examination room. Again, I try to only go in there when I'm, or get really close to the patient when I am actually doing, things like BIO or slit lamp examination. The rest of the time, I'm talking to the patient really at the door. Lastly, air purifiers. This is really, if you've been on Amazon recently, it's a hot commodity. Everybody's trying to buy air purifiers now. But from the research that I've done, the value of an air purifier is still sort of up in the air. So, I'm not sure if it's something you want to spend your money on. In a lot of cases, it says if you can introduce outside air, you're probably in better shape, just because of the fact that if you are trying to use an air purifier, the air purifier needs to suck in a lot of that air through the purifier in order for it to be effective. So it's one of these tiny little air purifiers that you have in the corner. It's probably not sucking in a lot of aerosolized air in it. So, how useful is it, especially if it's sitting on the floor where aerosolized air could be just floating around at head level? Again, how beneficial is it? So again, everything I heard thus far is, if you can increase airflow with outside air, that's probably the better way to do things. In terms of things like PPE, obviously we know that facial coverings are so important. It is one of these things that the CDC strongly recommends facial coverings for all, patients, I think above the age of 2. We actually have a hard and fast rule that facial coverings are necessary when patients come into our clinic spaces. We do have to tell our patients, we have to remind them, we have signage all over the place on how to wear masks. It does need to cover your nose and mouth because, you can breathe out some of the virus through your nose. So covering it, just using it to cover your chin is really not helpful, nose and mouth. Valved and vented masks. When it comes to things that are vented, as you guys should know, is that although they filter the air coming in, the valves allow air to leave. It makes exhalation easier. It allows you to breathe out a little bit easier. Unfortunately, when it does so, that air is completely unfiltered air. It's particularly tough, especially if your patient has a valve or vented mask that kind of looks like this, where it's a black mask and a black valve, to actually see that vent or a valve. And as I mentioned before, the idea here is that when air comes in, it's filtered, but when air is going out, the valve opens and you can see that the airflow goes around the microfilter. It goes around the filter, so everything coming out, if the patient coughs, sneezes, you name it, all that air is coming out, so it's not doing what it should do. That kind of leads me to this here in terms of, are all facial coverings the same? And there was a little bit of controversy regarding neck gaiters, and this was based on this particular study done out of Duke. One thing to note of this study is that this study was actually looking to see if they could make a simple, cost-effective way to rate masks. So that was the goal of the study. What they really used was a cell phone camera and a laser light within a box. So the idea here was, can we make a low cost, device that allows us to test masks? So the whole idea of the study was not to test masks, but was to actually, is a feasibility study to see how feasible using a cell phone camera would be. But it kind of raised a little bit of fanfare. So this is just a schematic of this study. And as you can see, the camera is over here. This is the hole where the person will talk through. A laser light goes through it, and you can see that it kind of highlights that microaerosol formation. But like I said, there was a lot of fanfare in this study because in this particular study, and they compared different types of face masks, what they did was they first did a control that's without a face mask, and that's this right over here. And they kind of set that to 100%. And they had up to 4 participants, mostly male, say a sentence 3 or 4 times. Actually, I think it was 5 times. And they counted, using an algorithm, counted the amount of droplets that they tended to see that went across that laser light. So as you can see, if this is 100%, we can see that things like bandanas, don't perform that great. Knitted masks don't perform that great. But, cotton masks or cotton blends actually perform really well. And of course, things like a fitted N95 and a surgical mask tend to perform really, really well. But of interest though, they call this a fleece neck gaiter. The fleece neck gaiter actually showed that there was more microaerosol formation as compared to not wearing a mask at all. And like I said, it kind of caused a lot of controversy. You might have seen all of those headlines and such. One thing to note is that they didn't really tell us what the, what type of gaiter this neck gaiter it was. It really wasn't well controlled in terms of, was the person sitting a little closer versus a little further away? They weren't controlling for decibels. Was this person talking a little louder as opposed to a little bit softer? So I think a lot of studies need to be done. But as I mentioned before, it kind of raised a little bit of controversy saying, is neck gaiters, is it worse than not wearing a mask at all? So at this point, at the college, if we see somebody coming in with a neck gaiter or with a bandana, we just actually tell those patients that we're going to give them a surgical mask to wear while they're on campus. So when in doubt, I think it's worthwhile to give your patients a surgical mask to keep your staff safe, keep your patients safe, and of course, keep you safe as well. To help digest this information, Business Insider looked at this study and actually looked at a couple of others that kind of ranked facial coverings, and this is more so for your patients and for lay people versus docs. This Business Insider article really talks about you really need to look at the actual studies itself, because the studies were all a little bit different and what they used as a gauge was all a little bit different. So that being said, big things to take away is that, obviously N95 surgical masks, they do a really good job of filtering droplets and aerosols. And this is filtering for the person wearing the mask. At the college, we have all of our students whenever they're on campus, they wear at least a 2-layer cotton mask. And then anytime somebody's wearing a mask that's maybe a silk mask or a scarf or bandana, these type of masks, I usually say that these are probably not good masks. I would say you want to switch out to give your staff member or your patient a surgical mask. As I mentioned before, when it comes to things like a mask with a vent, they do a pretty good job of filtering out large droplets and aerosols for the person that's wearing it, but it does not protect others. So you really don't want your patients wearing vented masks. So just as a heads up there. Last couple slides here, eye protection. This is something that, again, our last time we chatted was in May. So as of July, the CDC talks about eye protection. We know that there are things like ACE receptors within, the conjunctival tissue. This was a paper done in the summer as well with Jason Nichols, Lyndon Jones. And we do know that there are ACE receptors on the conjunctiva. So it is a possibility that if somebody sneezes, in your eye, that you can contract the virus that way. So that's why all healthcare practitioners, I think it's worthwhile to go ahead and wear eye protection. And that's exactly what we're doing at the college, as Dr. Poirier mentioned. But I do want to say that you have many, many more ACE receptors sort of in the airway and the lungs and such. So again, as a primary source, unless somebody really coughs or sneezes with a high velocity, with a lot of viral load getting in your eye, you're probably pretty safe. But again, it is one of those things that you do to be careful of. Lastly, before we leave here, I know we're a couple minutes over, I just want to say that in terms of resources, on our SUNY website, if you kind of click on this, the SUNY ramp-up plan, I have on there, and I think it's in the 50s, and in terms of the page, it's in the page 50s or so, I have on there all the cleaning protocols for things like your tonometry cleaning protocols. I have room cleaning protocols in there. I have different manufacturers, different devices. So we also have cleaning protocols for things like vision therapy devices and such. So again, it's a very good resource. So definitely go ahead and check that out. We're in the process of updating that. So continue to check back with our SUNY website, and that's sunyop.edu/coronavirus. At the bottom of that page, we do have a whole section on additional resources that we have. So it connects you right to the CDC, connects you to the Department of Health. It has all that information on there. So thank you so much, and let's kind of do some questions.
Thank you so much, Dr. Laul. I really appreciate you being able to put this together, and appreciate all of our speakers' time today. We're going to answer some Q&A, and Dr. Poirier is going to take over of the questions that we have. We don't have too many of them. Actually, right now we only have one. Dr. Poirier, do you want to take this one over?
Yeah, sure. This is for you, Dr. Laul. So with respect to droplet size and airflow, do you have any updated information regarding how long the virus is able to survive in the air, or more importantly, on a metallic or hard plastic surface? How long does the virus actually survive on those surfaces?
Sure. So from that one paper, as you saw, in terms of amount of time, depending on the airflow of the room, I mean, the airflow is so important. So that being said, it actually varied from anywhere from seconds up until hours. And even, in a vacuum, I think it's at up to potentially 5-6 hours or so. So if you're in a vacuum type environment, the coronavirus does tend to last in the air a lot longer. On surfaces, it depends on the surface. So when it comes to hard plastic and metallic surfaces, those surfaces, it can last for actually days. So, almost 2 to 3 days. On things like, porous surfaces, clothes, so if it's a natural material like a cotton, it'll last for a couple of hours. And most, if it's synthetic, it can last for a lot longer, so almost a day. That's why we tell our students, we wear scrubs now in the college, and we wash our scrubs, we wash our coats daily because of that. Oh, I see another. Yeah, I see another question here regarding the N95s. Yeah.
Yeah, we have some in the chat too, so we'll get to those as well.
Fantastic. So with regards to masks, KN95 masks are effective as N95s. The short answer is yes. The KN95s are, it's the standard that they use overseas, particularly in China and in Asia. But the idea here is exactly the same. So it filters out 95% of particles that are 2.5 sort of parts per million or 2.5 microns in size. So the short answer is yes. As long as it's from a reputable place, a KN95 is absolutely the same as an N95.
Okay. Thank you. Okay, so we have a couple of more as well. So Dr. Laul, do you have links to the articles that you referenced? And if you do, can you either post them on the SUNY Op website? Sure.
Yep, I can definitely do so.
Dr. Laul, if you want, you can also send them to me, and then I include it as a follow-up, to this webinar.
Absolutely.
So another interesting question: do you recommend putting a fan in the exam room?
Yeah, that's I think it helps with airflow. Airflow obviously is very, very important. One caution that I have, though, is that when it comes to things like that, that study that you saw from China, and that was at a restaurant study. So in that particular study, you can see that that air from the air conditioning was kind of bouncing back and forth. So if you have a fan in a closed room, how helpful is that? Probably not very helpful, because eventually you're just bouncing that air back and forth. If you have a fan that's in an open room, I think that's actually more helpful. Or, if you can set up a fan, let's say outside of your examination room, kind of blowing into your examination room, maybe moving the air around a little bit. But it really depends on the airflow of your practice. And I haven't seen a lot of studies on what sort of the best placement is for things like fans and such. So that's a tough question for me to answer, because I haven't seen much on that.
Yeah, that's an interesting point, really. All right, so we have another actually mask question. So what do you think about the different filters that can be placed inside of the cotton masks? I know I've seen a lot of this labeled, a lot of the cotton masks, you can buy the little filters that insert masks.
Yeah, exactly. So usually with those cotton filters, cotton masks, from that Duke study, you can see that those cotton filters actually or cotton masks, those 2-layer cotton masks, are very, very good. So even on its own, it's actually quite good. If you go ahead and slide those filters, and those filters are usually similar filters to N95 masks. It usually says something along the lines of 2.5 parts per million. That actually just gives you an added level of protection. So I would say a cotton mask on its own is completely fine. For a little bit of extra protection, by all means, you can go ahead and put that filter on there. I don't know how much improvement that you get, because a 2 or 3 layer cotton mask is actually pretty good. Is it going to be the level of an N95? Probably not. And reason being is that the N95 is fit for your face. It has seals all the way around your nose and mouth, so it's a lot more effective. That being said, it is one of those things where, sure, but even having a 3-layer cotton mask is probably pretty good.
Thank you. All right, so we have another interesting question here. So when patients fog up their glasses, aren't they increasing the exposure to their own droplets? And does more circulating air by not wearing protective eyewear have any beneficial effects? And it's similar to opening the doors in your office.
Right. So the idea, of course, wearing masks or glasses, in general, is that you're protecting. So the reason that we wear eye protection is that you're protecting, if somebody coughs or sneezes in your face, that you're protecting yourself against their virus. If the patient already has the coronavirus and they're breathing onto their own glasses, it probably really doesn't matter much. I think I always tell all my patients that anytime they take their glasses off, they should wash their hands prior to, clean their glasses either with soap and water or appropriate cleaning solutions. Always keep your glasses clean before taking them off and putting them on. So I think it's one of those things where if somebody fogs up their own glasses, as long as they're taking on and off their glasses in an appropriate manner, I think they should be in pretty good shape.
Actually, kind of a quick follow-up to that, I have a question that's along the same line, was that, so when you're doing 90D on your patients, a lot of the time these patients are fogging up your lens as well from their mask. So what would you recommend, cleaning the lens with afterwards?
Yep, absolutely. So it's actually on, so I'm glad you brought that up. It's actually on my my protocol. So I have info from like Volk lenses and such. Those lenses can be cleaned with alcohol. So I actually use an alcohol pad after I did 90 on a patient or BIO on a patient, and I clean my lenses off that way. So I disinfect them off that way. And then I use a lens cloth to clean to kind of clean off the debris from the alcohol. That's a great question.
Thank you.
Yep.
So another question here. So due to the ACE2 receptors on the conjunctiva, do you recommend deferring tonometry as it not cause inflammation and activate those receptors?
Well, again, I think eye care is pretty safe, and then from what I see from Goldman, I think that is pretty safe as well, as long as you're cleaning, doing the appropriate cleaning protocols. So I haven't seen anything stating that you would agitate your ACE2 receptors by doing tonometry. So I haven't seen that yet.
Yeah, and also goes along to a lot of the receptors, the virus attaches to it. So I think just the actual act of, manipulating the front of the eye won't really activate the receptors.
Okay.
I know.
Yep.
Yeah. Good question. Can you briefly summarize a recommendation for day-to-day exam room sterilization for a doc with a small practice wanting to know?
Sure, absolutely. So, essentially what we tend to do at the college is that I have a cleaning protocol set up, and that's also on that college website reopening plan. We use cavity wipes. So between every single patient, we cavity wipe the chair, the foreopter, the stand, any knob that you might have touched, doorknobs, light switches. I actually use to clean off the knobs on my BIO. I actually clean off the keyboard and the mouse. Anything that I can possibly touch, I tend to clean it off with the cavity wipes. They need a 3 to 5 minute contact time. So clean that off there, and then I bring my patient to the examination room. I try to be as efficient as I can be. I do my history and anything else I need to do from the door, so I'm as far away from the patient as possible. And I only kind of move in when I need to do a slit lamp or when I need to do a BIO or something like that. Patient wears a mask, I wear a mask, visors are needed. We have BIO shields, we have slit lamp shields. We actually started using some foreopter shields that we're kind of playing with as well. All of those do get cleaned with the cavity wipes between patients. Any handheld that I'm using gets cleaned via alcohol. The base of the tonometer, if I'm using Goldman, so the dial, for example, that actually gets cleaned via alcohol. The tabletop of the slit lamp gets cleaned. So yeah, I mean, the cleaning protocol, like I said, is actually on the SUNY website, so definitely check it out. But that's exactly what I do.
And kind of going along with that as well, another doc wrote, how effective is cleaning the slit lamp and foreopter with the alcohol wipes? I know we don't actually do that at SUNY. We use the strong wipes.
Yep. So 70% alcohol is actually very effective against the coronavirus. So as long as 70 and above, you should be in good shape. The reason we use cavity wipes is that it cleans off, because it's hospital grade, it actually cleans off other things as well. It's effective against certain types of hep and HIV and other things like that, whereas alcohol may not be as effective against some of those other types of viruses and such. So that's why we tend to use the cavity wipes. But for coronavirus, alcohol is perfectly fine for slit lamp and foreopter, as long as you clean off the whole thing, anything that a patient touches or can breathe on.
Perfect. All right, and also this is actually an interesting question. Is it safe to wear a face shield without a mask?
According to the CDC, they do not recommend it. So I would recommend wearing a face shield and mask.
Perfect. Thank you. And they're asking, what type of wipes are you saying? I think it's cavity wipes. How do you spell it?
CAVI-wipes. Yep. You can actually, or any sort of hospital grade wipe. So there's quite a few that you can look. On the EPA website, there is actually a full list of approved cleansers or cleaners. So there's Clorox wipes, there's Purell hospital grade, cavity wipes is on there as well. So yes, I would actually recommend looking at it's under the EPA website. It has a full list of approved cleansers.
Okay, thank you. And it looks like we have no further questions. Oh wait, maybe one more?
Yeah.
Oh, no. Thank you. Thank you.
Thank you everyone for tonight. Thank you, Dr. Poirier, for handling the Q&A part, and to all of our panelists for taking the time today, as well as all of our attendees to join us on this important webinar. We look forward to seeing you either at the recent, or not seeing you, but here having you at the recent optometry program, as well as at Envision New York. More information for this will come out. Have a good night. The recording of this will be made available tomorrow, and it will also be on our website. Have a good night, everyone. Thank you.
Good night, everybody.
Night.